For dysplasia, the commonly used classification is the Crowe classification, which is a ratio of the pelvic height, and there are 4 groups. I'm not going to go into details, but a more practical classification is the 3 classification where you combine group 2 and 3, where you have contained what is known as low or partial dislocations and high dislocations. So what are the surgical challenges in a dysplastic hip? Your acetabulum is severely anteverted. Rarely it may be retroverted. There's very thin bone medially, and in the type 2 and 3 Crowe, you have a superior deficiency. In the femur, you've got a short neck which is anteverted and highly valgoid. The distal canal is very narrow, and your medial flare can be narrow. So essentially, your primary stems are not going to fit in these femurs. And lastly, you have the soft tissues where you have the thick capsule and labrum, and your tendons and sciatic nerve are the big issue, because if you need to excessively lengthen, you may land up damaging the sciatic nerve. So let's look at the femoral options. You can use a cemented CDH stem, which has a very thin diameter and a short offset. You could use a Wagner stem, the primary Wagner stem, or you could use a modular stem like the SROM. And in the acetabulum, what are the strategies? You go with small cups, because very often you need a 38 mm cup. You ream into the good bone, and if very often you need to leave large parts of your cup uncovered. You can go with a high hip center, or you can go with an anatomic hip center with or without bone graft. You can do a cartiloplasty, or what I personally prefer is controlled medial perforation. I have never used a cage, though it has been described. Not for dysplasia, at least, not a cage for dysplasia. And now you have the newer options. You have the porous cups, you have metal augments, you can do 3D printing, and you can make customized cups. So what is the studies show about cemented versus uncemented cups in dysplasia? Because you're leaving large parts uncovered, by and large, cemented cups have a poorer track record, so most people prefer uncemented cups except the hardcore cemented fans. Coming to the high hip center versus normal hip center, now if you look at this sort of hip, you can see there is severe bone deficiency. You can't really, you have no option except to put the cup high, as I have done here. What are the advantages of high hip center? You're going into good bone and you get better, you're simplifying your surgery. The problems though are you're creating insufficiency of the adductors and you're increasing your hip loads. But studies have shown that up to 15 millimeters or even up to 2 centimeters essentially is not going to significantly impact your long-term outcomes. So let's look at some examples. Here, a pretty straightforward Crowe 1 case. What I've done is a controlled medialization. So I've elevated the hip center by maybe 5 mm. Part of the cup is uncovered, no allograft. I've used a monoblock cup. This allows me to, so even with a 40 or 42 mm cup, it allows me to get in a large head, and a primary stem is good enough. Now, a more severe case. Here, the acetabulum is not such a challenge. There is adequate bone here. You just need to use a small cup with the controlled medialization. It is your femur which is the challenge. The canal is very narrow. This sort of thing, I have used a SROM stem here. What is the advantage? It comes in very small sizes from 6 mm onwards, multiple neck options. You can dial your neck in independent of your proximal anatomy, so you can address the meta and diaphyseal mismatch which exists in these cases. Now coming to the type Crowe 2 and 3. So you have a superior deficiency because the head has eroded and created a sort of false acetabulum there. So your options are to go high or go low. What is my personal preference? I like to put it as anatomical as possible for the cup to give you a firm grip. So I won't put it so low that I don't get a good grip on the cup, but I won't put it in the false acetabulum either. And the part which is uncovered, I usually use the autograft. The autograft does not give support to the cup. The idea of the autograft is just to build up your bone stock for the next, for the future. And if the cup is unstable, I feel there's slight instability in the cup, then I'll use a metal augment. So here you can see a case where it's a type 2 Crowe. I've used a standard cup with a bone graft and a Wagner type of stem. The advantage of the Wagner stem, again, it comes in very small sizes. It has a 125 and 135 degree neck, so you get two options, and having no metaphyseal flare, you can dial your stem in the desired version independent of the proximal anatomy. Excellent long-term results, we all know that. Now coming to the autograft. Does the autograft really work is a slightly debatable issue. Here you can see a case of mine. I've done an autograft, but see what happens after 2 years. The autograft largely, very often gets resorbed, which is why you cannot rely on the autograft to give you primary stability. And if you want primary stability, you need to use a metal augment. Now let's look at the most complex case, a type Crowe 4, where you need to do a shortening osteotomy. The technique you'd use is first expose your acetabulum, release all your soft tissues. Then you do your, but don't put in the cup yet. Next, move on to the femur, do your distal reaming, do your proximal reaming. Now take your osteotomy just distal to your proximal reaming. Having done your osteotomy, now you put in the cup. That will, 10 seconds, put in your cup. That will give you, that osteotomy will give you that additional space to maneuver. Then reduce your, put in your femur without putting it into the distal stem. Reduce the femur, hold the distal stem, see how much you need to cut as you, and then you take your cut and then put in your stem into the distal portion and reduce it. So here you can see a bilateral type Crowe 4 and the post-op X-ray with the S-ROM prosthesis. Thank you.